Continuing with trial design, we'll look today at early phase trials, the possible designs for early phase trials, a little bit of the theory behind them, or where they came from. We'll differentiate rule versus model-based designs, and we'll talk about appropriate endpoints for early phase studies. Some things that you should take away from the presentation today. What are the common phase 1 designs? And what are the pros and cons of rule-based designs versus model-based designs? So remember, for early phase designs, by definition, these trials will have a small number of people or participants. There is concern you could expose too many participants to an intervention that is high risk. So this is where you try to balance safety with efficacy. And of course, the push for getting interventions to market faster, whether it be a surgical or medical intervention in terms of FDA approval, is that you don't want to get very far down the line in drug development or a surgical trial or a medical device before you start finding out that there are safety issues. And so these studies will typically start with smaller numbers of people to figure out whether or not there is a safety risk. So how do you figure out which design to use? So we'll start first with some early phase definitions. And this is just a small number or a small sample of the most common definitions that you would know if you worked in early phase designs. So there's a lot of acronyms here. And the reason for that is they're fairly wordy. But let's walk through a couple of the most common. If you have your early phase worksheet, you can see if you can match up these terms with their definitions. So the first two here on the left-hand side, PK and PD. This stands for Pharmacokinetic and Pharmacodynamic. Pharmacokinetics is defined as the study of the time course of drug absorption, distribution, metabolism, and excretion. So this is basically looking at how a medication or a drug is absorbed and metabolized and released from your system. So this isn't actually about whether or not it is working, whether or not it's making someone feel better. Pharmacokinetics is solely about enhancing the way that the drug is functioning in the system and decreasing the toxicity. So pharmacokinetics is drug absorption, distribution, and metabolism. Very closely related is pharmacodynamics. Pharmacodynamics refers to the relationship between drug concentration at the site of action, so whether it's supposed to be acting upon the brain or the liver or the whole body, and the resulting effect, including the time course and intensity of therapeutic and adverse effects. So pharmacokinetics and pharmacodynamics are closely related. Pharmacokinetics is looking at how it's processed through your system, and pharmacodynamics looks at the concentration of that medication related to the effect of the medication. So those are some very basic definitions. Following that up is PGDE. And if you ever work in phase 1 trials, PGDE is something that you will encounter quite frequently. This is pharmacokinetically guided dose escalation. So if you pull apart those words, pharmacokinetic, that's how it's working in the system. How long does it take? How long does it take to metabolize? How does it get out of the system? Guided dose escalation. So they're going to let, in this type of design, the pharmacokinetics guide whether or not we increase the dose. CRM, another very common type of phase 1 trial, is the continual reassessment method. So you are, in fact, continually reassessing the results of the study. A secondary to CRM is something called the tight CRM, and this is time to event CRM. So in some cases, your objective might be to measure something, so a metabolite. In other times, your objective may be waiting for a level to hit a certain pre-specified point or endpoint. And so you'd be doing time to event. So that would be a tight CRM. The EWOCs are not little fuzzy Star Wars characters. EWOC is escalation with overdose control. So they are slowly escalating the dose of a medication, looking for or trying to prevent overdose control. When you see the little M, Here in MTPI, the little m stands for modified, as it does for modified intention to treat. Here it stands for modified toxicity probability interval. So an MTPI is looking at a toxicity probability interval. That is, what is the likelihood that you would reach toxicity at the next time period? The second column here on the right begins with POM, and this is not a pomegranate drink. Actually stands for proportional odds models. So it's looking at the odds of something happening proportional to what has already happened. OBD is optimal biological dosing. So we're really looking for what's the most optimal level in terms of the outcome that we have in mind, pharmacokinetically or pharmacodynamically. RP2D, again, not Star Wars, recommended phase 2 dose. So the point of a phase 1 trial might be to reach the recommended phase 2 dose. MTD, MAD, and MTA are somewhat related. Maximum tolerated dose, maximum administered dose, and molecularly targeted agents. And then we have DLT, which is the dose-limiting toxicity. So how do we employ these various definitions? As you go back through your worksheet, you can reference the definitions here.